Imagine living with eye pain that you can't escape from. Not a headache, not irritation. This is eye pain every time you open your eyes. Every blink and for every second. For some people with severe dry eyes, this is daily life. In addition, while some people are feeling this unbearable pain, others may not feel anything at all. Yet, the surface of their eyes is breaking down and not healing. Both conditions can be devastating, and both are misunderstood. These conditions are referred to as corneal neuropathic pain and neurotrophic keratitis, both of which can be caused by or complicated by severe dry eye disease. So in today's episode of the Dr. Eye Health podcast, I'm joined by two leading experts in eye care who come from different clinical perspectives and share their insights into dry eye pain, and how inflammation and nerve damage affect eye health. We've had several people in the comments ask about this advanced topic, so I'm excited to share. Now, just a quick moment before we begin, I just want to call out that I've been looking at our channel statistics and see that only about 9% of our viewers actually hit that subscribe or follow button down below. And so I do ask, if you have found value in our content, please take a second of your day to hit those subscribe and follow buttons. It does go a long way and help us grow this channel, help us reach more people, and it helps us continue to bring on such excellent guests. All of which to help keep you healthy and keep you seeing your best. So with that, let me say thank you, and let's get into it. Thank you guys both very much for being here and being part of this project. I do want to start off by inviting both of you to kind of explain, of course, who you are and where you practice. And in the severe cases of dry eye that you manage, in your experience, do you also confront neurotrophic keratitis and neuropathic pain? I know it's a big question, but again, kind of tell us about your practice, your experience with running into that.
Hi, everybody. My name is Laura Periman from Seattle, Washington. I'm a board-certified ophthalmologist, and I'm cornea and refractive surgery fellowship trained. And I run the dry eye services and clinical research here at the Periman Eye Institute in Seattle, Washington. And my interest in dry eye is long and deep. Dates back to when I was in medical school, my interest in dry eye disease. And before medical school, I worked as an immunopathophysicologist, in the molecular biology lab at Amgen, or what is now Amgen, what was Immunex way back in the day. And so I really love inflammation and really deeply understanding how things work. And that's the crux of what we do here, is like we deep dive into how things work on dry eye disease and some of these other conditions that often co-migrate with dry eye disease. And so that's how my interest in neurotrophic keratitis and neuropathic pain came about.
So my name is Jacqueline Theis, and I practice in Richmond, Virginia. My practice is completely different. I am an optometrist by training. I did additional residency training in neuro-optometry and ocular motor function, so eye movements, completely unrelated to dry eye. And my practice is a subspecialty center that's part of a multidisciplinary brain injury center. So we have an outpatient center and an inpatient center. And I've been practicing in traumatic brain injury and acquired brain injury, working with patients with visual complaints from those conditions for the past decade. And I have never been interested in dry eye. I have hated dry eye. I am the atypical person that likes double vision and eye movement problems and atypical visual complaints. And the problem I've had for the last 10 years is everybody with brain injury has really bad dry eye. Yeah. So I've had to learn dry eye. And to answer your question on neuropathic pain and neurotrophic keratitis, I find that's more what I'm seeing. And I've been frustrated in the last 10 years because every time I've gone to a dry eye lecture and I try to bring it back to my practice, it hasn't worked very well. And it's because the etiology of the dry eye for my patients is the neurosensory pathway. Yes. It's not the inflammatory pathway. And so I've been kind of in this space for a long time of the neurosensory etiology of why are the eyes dry? And some people do bring with them inflammation. And that's when I usually will co-manage with someone who does cornea or kind of ocular surface specialty, because it's not mine. And where mine has come in as a specialty has been neuropathic pain. So most of my patients are seeing me for abnormal persistent photophobia, atypical visual disturbances, blurred vision after brain injury or brain surgery, which can often be neurotrophic keratitis or neuropathic pain.
I love that. And you're so right that the neurosensory component of dry is just a valid part of the definition as the inflammation, right? And these worlds come together and clash or mesh, depending on your proclivity, into something that you can use to help your patients. So I really love that approach, and I can't wait to learn more from you.
I think really what we're getting back into is how complex dry eye is, right? And so from even like a patient's perspective, it is overwhelming because you don't really know what's going on, right? I think the very simple perspective, a patient will think, my eyes are dry, or my eyes aren't dry. In fact, they're wet, right? There's a lot of complexity to it. But like you mentioned, a big part of is inflammation. There's some people that inflammation plays a big role in dry eye, but then there's this kind of extra wrench and a half of what's going on neurologically that can really complex things. And if you don't mind, Dr. Theis, would you, with your expertise and knowledge, because I know off the top of your head, you can probably picture and explain exactly the pathophysiology of what's going on with the nerves. Would you be able to kind of give us a brief rundown for anybody listening in of how things are connected from the eye to the brain, from the brain to the eye, just in terms of sensory?
Yeah. So for the longest time, people in dry eye will talk about how the signs and the symptoms of dry eye don't make sense. And if you understand how the eye is innervated from the brain, the signs and symptoms actually do align depending on the patient's condition. And so to take a very complicated question and make it as simple as possible, I always say that we have the central nervous system, which is your brain, and your peripheral nervous system, which is everything else. And the brain uses that to sense the environment, to maintain all of the cells on the outside. And so your eye is kind of a sensor. And it's allowed to sense the environment and how you blink and how much tears are on the surface. And the brain does that with the trigeminal nerve. And so when something goes awry, whether something gets in your eye or you're evaporating too many tears, the signal from the eye goes to the brain, and it's such a long signal. And that's where I think people have to recognize that a lot of conditions can co-present with dry eye, because you have the first neuron is going to go from the eye, it's going to go all the way back, and the first synapse is actually at the top of the superior cervical ganglion in the neck. So then it joins with the afferent sensors from the neck, and it goes up to the thalamus, and then from the thalamus it branches out to the cortex so that you can recognize pain. The brain decides what it wants to do with pain, and then it sends a signal and a response back. And to make it even more complicated, the brain has these reflex arcs as well, because that 3-order pathway can be slow. And so the brain also has some quicker pathways that will cause reflexive tearing, right? If I get something in my eye, I'm going to quickly tear. That's a different pathway than if I just chronically have dry eye and have tearing abnormalities. So it's a very intricate balance. How many tears you produce, how frequently you blink, all of that is regulated by the brain. And so when someone has a brain injury, that can be impacted. When someone has inflammation on the surface, that can be impacted. And then they all kind of go together. And I think the hard part about dry eye is it sounds like a simple diagnosis. And it's not a simple diagnosis. It's not. So
what's your experience, Dr. Periman, with like the diagnosis of like something like, because we haven't really touched on neurotrophic and neuropathic pain, but
I think we're going to get there. But
yeah, I would love to like kind of hear both of your guys' perspective on like what's going on. Like at what point do we have this breakdown where we start to see changes in the surface and the symptoms that a patient would experience?
That's another big question. I think
this is a huge topic.
It is a huge topic, and I'm trying to be as granular as I possibly can be. I cast a broad net with each and every patient. I want to know, did you play soccer and get soccer ball injuries, concussions as a kid? Have you had car accidents? Like, I want to, do you have chronic sinus disease? Like, I want to know all these different things about them because it helps organize my approach. Because to your point, dry eyes can be inflammatory, but it can also be neurosensory. And so those are different diagnostic and treatment pathways that I'm exploring, and I need to know which one to go for first or concomitantly. Like they often go together. To your point, many head injury, concussion type patients present with dry eye, and how I explain to the patient is the system's been a little short-circuited. We need to hotwire the car to get this normal tear production running again. So I really cast a very broad net. I do the diagnostics. What's your osmolarity? It's going to be abnormal in that situation, right? Yeah. The MMP9 or the inflammatory load may or may not be abnormal, right? You may or may not see meibomian gland changes yet. If they're not blinking properly, you probably do have meibomian gland changes and drop out from that incomplete blink and exposure potentially. Corneal sensation. I am testing more and more corneas with a Cochet-Bonnet. Like, it's one thing to screen test with like a clean dental floss or with a wisp of cotton, but it's another thing to use the Cochet-Bonnet or even the Brill aesthesiometer, because now I can quantify where that is and I can track my patient's response to therapy, which I really like. So I'm doing that more and more and more, looking at corneal sensation. Obviously, the vital dyes are super important, but I also pay close attention to the blink mechanics. I'm counting the blinks, the pattern of them. This tells you a lot when you're looking at a patient, what the problem is. Is the blinking just not going down all the way? Is there excess drag on the face from the lids descending, or in our really young, lean patients, they may not have enough cheek to support the orbicularis muscle. And that poor little paper-thin muscle just can't support the weight of the face. And that results in excess trigeminal tone, which results in further dry eye, exposure, neurosensory compromise, and inflammation. Oh boy, here we go around the mulberry bush, right? So I take a very broad approach, and I'm looking for very specific things, but I find myself becoming even more detailed observer than ever before, because there's so many nuances to all these different components that we encounter clinically.
Yeah, I think one of the things too, when you're doing blink rate counting, and I always, so in my office behind the patient, I actually have a clock that just says the old, you can't hear it, but it has the nice seconds going around, so that while I'm talking to the patient on the side, I'm actually counting how many times they're blinking while they're just talking to me to get their basal rate.
That's impressive multitasking. I can't do that.
Well, one of the problems is once you're on the slit lamp, they're trying to keep their eyes open for you.
Right.
So it's not a good basal rate count. And so looking at kind of that exposure is a big deal for me. And the other thing that you mentioned that really resonates with me is this: it's cyclical. And so it's very chicken or the egg when it comes to the neurosensory aspect. Mm-hmm. So I always say pain has a purpose. We do want to feel pain. And what should happen is something happens to the eye. Maybe we get a cut on the eye. A signal is sent to the brain recognizes it, it sends more tear factors, it sends inflammatory markers, it wants to fix the problem. And technically, in a perfect world, whatever happened, the inciting factor goes away, the wound heals, and the inflammation goes away. And that's how eye care should work on those acute cases. Where it goes awry is when someone has chronic damage to the eye, and then they get inflammation, and the inflammation, what it can do is damage the neurons receptors. And so now what'll happen is, let's say I need this amount of pain or problem to send a signal to the brain. Well, if you have persistent inflammation, the receptor gets damaged. So now the receptor, it'll fire if it only gets this much pain. And so you get all of these people who are hyperalgesic and who come in and it doesn't look that bad to us. And that's the hard part, I think, in eye care, is being careful not to gaslight your patient and being like, it doesn't look that bad. Because
please don't say
if they've had it chronically, and they're doing I'm doing the lid scrubs, I'm doing the lid hygiene, they're really doing their best, it doesn't look bad. But the hyperalgesia, the allodynia, which for those who don't know those terms, essentially what shouldn't give you so much pain gives you a very large pain response, and it's a real pain response, is lowered, and it's because of the inflammation. And so then it becomes this bad cycle, because then you get nerve damage, and when you have damaged nerves, guess what tries to fix it? Inflammation.
Yeah.
So then you get more inflammation.
Yep.
And then you get more damaged nerves, and you just cycle down, right? You're cycling the drain at that point. And then it's, what do you fix first when you get these chronic cases? And I think that's the hard part of the neurosensory aspect of dry eye is, you have to treat both. And sometimes the order matters, and you don't know necessarily when you get someone where everything's just gone wrong for so long.
I love that. And, we even have confocal evidence of the nervous system, the furthest anterior reach of the nervous system, talking to the immune cells in the cornea, the dendritic cells. They're talking to each other all the time. Hey, how you doing? Are you doing okay? Yeah, I'm great, bud. How are you doing? Great. Awesome. Everybody's happy. But if you have damage to those nerves, then the inflammation comes in and tries to fix it. If you have the nerves misbehaving, then it cites more inflammation. It's this dance. It's this crosstalk that ideally we want to have a civil conversation between the two, but sometimes they're at odds. Yeah. So I think that there is ultrastructural things. And to your point about not gaslighting our patients, that's so important. I'm so glad you said it, because just because you can't see it doesn't mean it's not real. Yeah. There's so many examples of that in medicine. There's so many things where we just don't have the tools to measure it in a clinical setting yet, right? So, but that doesn't mean it's not real. So yeah. Listen to your patient. They're telling you the truth.
Yeah. And I think to the point of listening to the patient, it's also recognizing there's so many factors to it. And particularly in brain injury, obviously, just from my experience, brain injury is a multidisciplinary problem. And so sometimes it's the other parts of the brain. So maybe the brain got injured and maybe it's the superior colliculus, so my blink rate is off, or whatever aspect of the ocular surface mechanism that's off. Sometimes it's totally normal. And the problem is, hey, since the brain injury, I haven't slept more than 2 hours in 3 months. Yes. Hey, since the brain injury, I got put on 4 new, migraine medications or pain medications for the arm I broke. And that's actually where it's coming from. Or a lot of people get trigeminal neuralgia and then they get treatment for trigeminal neuralgia and then that causes dry eye. So for me, it's the talking to your patient, getting the full spectrum and recognizing that it might be multiple reasons that they're having. And that's where I think we see all the chronic cases is half of the exam is the intake.
Yes, I would agree with that. If you really listen carefully, it'll guide you.
Trying to really pull it back to this concept that there is something called neurotrophic keratitis, and there's something that happens that's called neuropathic pain. Really, I think from both a doctor's perspective, really frustrating, and from a patient's perspective, equally just what is going on? Why are these treatments not helping? Or why is it that my vision is terrible, but the doctor's telling me it's this terrible thing, but I don't feel like it is, right? There's a disconnect. So I'm curious from you guys' perspective, would you guys be able to break down just what's going on neurotrophic keratitis-wise? What's going on neuropathic pain-wise? We've touched on neuropathic pain a little bit already.
Yeah, well, I'll take a quick go with that. I think of them actually as a spectrum, not as an either or, yes, no, but rather a spectrum. Because if you look at it ultrastructurally on confocal, you'll see that you can have a mixed picture of neurotrophic and neuropathic, right? Increased dendritic cell activity and pruning or neuromas, or you can see all these different things. I think it's actually a spectrum. We know that inflammation drives abnormal nerve differentiation and morphology. It's in response to acute phase cytokines, IL-1 and TNF. So I'm always looking for what can I do to address the inflammation load that's driving this process in the cornea, and whether it's neurotrophic or neuropathic, I want to pay attention to that as well. But there is some ultrastructural evidence of what is actually going on. None of us have that tool. Well, actually, you may have it at your center, and that's awesome. I'm super envious. I don't have one. They're hard to come by, confocal microscopes. But so I view them more as a spectrum. And because I'm a cornea ocular surface disease person, my interface with the neuropathic part is often in the context of chronic dry eye, chronic inflammation, right? Yeah. Coming at it from this end of things. You're coming at it from this end of things, and the poor patient's caught in the middle. Things like chronic rosacea that's untreated, chronic blepharitis, chronic meibomian gland dysfunction, all of these chronic inflammatory entities beat up on the cornea, beat up on the corneal nerves, can result in neurotrophic changes or neuropathic changes. So it's I don't quite understand which patient becomes which yet. You probably have some ideas on this, but when you look at it from a external disease standpoint, there's a lot of overlap with this spectrum of neurotrophic and neuropathic.
Yeah. So I was actually creating a lecture for this topic a few weeks ago, and what fascinated me while looking through the pathophysiology is that there are some etiologies that share both neurotrophic keratitis and both neuropathic pain. And for the audience, neurotrophic keratitis is when you have things that we see. So we see that there's problems with the cornea and you don't feel it. Oftentimes patients will come in, they feel great, they're just routine exam, blurry vision, and we put some color dye on the eye and it's lighting up like a Christmas tree because there's so much damage that the blur is coming from damage on the eye. Neuropathic pain is the opposite, where the patient's coming in with severe pain and you look, and sometimes there's damage on the eye, but oftentimes they look fine. And so what's interesting is those sound like totally different conditions. And if you really look at the pathophysiology, especially for some of the ones that have the same etiology, chronic dry eye, chronic contact lens use, history of refractive surgery, all of those are similar. And we don't know why some people go the neurotrophic route and some people go the neuropathic route. There are some conditions that are very different. For example, trigeminal neuralgia. I have trouble with my trigeminal nerve. It is causing too much pain, or occipital neuralgia. That's going to refer pain to the eye. That's not going to cause a neurotrophic anything. What'll cause neurotrophic keratitis is when you treat the trigeminal neuralgia. Now you get neurotrophic. So that's where the spectrum changes. So essentially, when you have trigeminal neuralgia, your nerve is overfiring the pain signal, and it's so painful that oftentimes we can do injections. So in my clinic, we have a physiatrist who works in brain injury medicine, and if we have occipital neuralgia or trigeminal neuralgia, we will either co-manage with a pain specialist, or depending on the level of where it is, and that's why working in a multidisciplinary center is so great, he can inject the nerve, or there are some neuromodulation that our physical therapist can do for depending on which nerve it is and where. Sometimes just ice, right? So nerves fire faster if they're heated up. And so just putting on an ice pack will slow the nerve down and the pain will get better. So there's a lot of treatments for those kinds of conditions. But the problem is if you're going to inject the nerve, or some people, the pain is so bad, they have to go in and they just cut it, right? They're going to go in and essentially do surgery to alter the nerve.
Yeah.
And then once you cut it, the problem is pain has a purpose.
Yeah.
So now you can't feel your eye, which means the eye is actually at a very high risk.
Very vulnerable.
Of infection and trauma and things like that. And so And that's where I actually get a lot of my patients. It was beautiful listening to your clinic because our clinics are so different. Because for my patients, the first thing that I'm worried about is usually a neurotrophic or neuropathic problem, especially if they're post-surgical, like post-brain surgery or post-surgery after an acoustic neuroma, because I know they had to cut the nerve to get in there. And so I'm looking for that first. And that's kind of where the difference lies, is that's usually what I'm looking for first versus inflammation. And I think that's the big key for any eye care provider out there that sees someone after a brain injury or after neurosurgery is anti-inflammatories are probably not going to work, right? And because it's not an inflammatory problem. And so you can't hit it with an anti-inflammatory unless they've had it for so long, they then also have inflammation. But if you saw someone and they're like, I had a car accident last week and I woke up the next day with dry eye, it's not an inflammatory dry eye at that point. Yeah. If you don't treat it, you can definitely let it get there. But it changes how you treat it. And I think that's the other key that you and I think make us different is there's no one battery that you do everything for every patient is different.
There's no protocol, right?
There's no. Yeah.
Interesting. I'm interested to hear more about your physiatrist that does the injections, because you'll be happy to hear this. Sometimes when I get that history of some kind of trauma or injury, I'll actually palpate the neck and see if there's point tenderness back here. And sometimes I'll put a little lidocaine injection there to see if I can give some relief. So I do that detailed neurosensory exam. But we've noticed that a lot of our dry patients have bruxism, which is a medical term for teeth grinding or clenching. And that can be day or night. But we're finding that when we inject those with neuromodulators like Botox to the area, we can calm the excess tone in the trigeminal nerve, and that helps the normal neural flow of tear production to resume and improve. Just by turning, I tell my patients, we're turning down the volume on this raucous party inside the trigeminal nerve to allow the normal neural flow of your tears to resume.
Yeah. So, and the Botox is a great option for those patients. The other one is also orthopedic PT. There's a lot of physical therapists out there that can do TMJD or we have one in our clinic who's amazing at working on the muscles. And so one of the things that she taught me was anyone who has temporal mandibular joint dysfunction, right, or TMJD or bruxism has a neck problem. And she's like, not everyone with a neck problem has TMJ, but everyone with TMJD has a neck problem. And so when you treat this and you treat the neck, that also helps. And that's that part of that
And is it
referred
because of the
pain.
tail, of the trigeminal nerve tail? Is that why?
So it has to
is
do
it like
with
an adjacent, what do you call that pain where you're having a heart attack, but you're nauseous and your arm hurts? Referred pain. That's the word I'm looking for.
So the neck can refer its pain, whether it's neuralgia or not. And that's kind of the interesting thing. But all of the muscles are interwoven with each other. And there's amazing things that I've learned working in our clinic on how things from the neck can refer to the eye. Mm-hmm. And that's the beauty too, is people will come in and they'll be like, oh, I feel this eye pain. And like you, I do a palpation. So there's 7 specific muscles that go right to the eye, and each one's different. There's the needle through the eye versus the orbital pain. And you just have them touch their neck and they're like, oh, my eye pain's gone. And you're like, yeah, because it's not secretly an eye problem, it's a neck problem. Mm-hmm. And then you send them to a neck person and they go away. So the same thing with the Botox of I relax the jaw, which relaxes the neck, and then it kind of has that wonderful downward cascade.
We're touching on a topic I know that we definitely need to do a future episodes for content on things like YouTube and podcasts, because the neck is a mystery area. At least to myself even. I know it's something I haven't been super proficient in educating myself on, so it's a next area I need to learn myself. And clearly there's a lot of connection to the eye and to symptoms my patients are experiencing with ocular pain. What are we all doing now, right? We're all spending so much time staring at our phones, sitting in poor posture, the ergonomics. I'm even myself. I'm just thinking like I have terrible posture.
Physical therapist teach me this amazing trick. I'd had a couple of bad rear-ending car accidents. None of it was my fault, but I'm like all beat up and sore and barely move, whatever. This physical therapist taught me this amazing trick that I want to pass on to our patients and our viewers. This part of your head where the hairs swirl, this is how you come into the world. If you stand, just in mountain pose with your feet shoulder width apart, your arms gently relaxed at your sides, and you lift this part of your head to the ceiling, it corrects all 5 curves of your spine without straining, without like feeling like you're twisting yourself. You just lift, and it corrects everything. It elongates the spine, relaxes the tension all in the spine. It's powerful. Combine that with square breathing, that'll relax things real quick.
Yeah, no, I love that. And I think you're right. I think it's a huge topic to talk about when it comes to neck pain. And that's been a big one for me, is when we go to circle back to neuropathic pain, one of the big tests that we'll use for neuropathic pain diagnostically is the Proparacaine challenge.
Yes.
And so essentially what we do is we put Proparacaine or an analgesic on the eye and see if your pain goes away. And if it does, then we know that the pain is coming from the eye's receptors. Much easier to treat. It's nociceptive pain. If you put something on the eye and they're like, no, it feels dry still, then you know there's possibly, and I always say possibly, a neuropathic component. And the reason I say possibly is because if it's coming from the neck or the jaw, the Proparacaine challenge will still be negative or be positive in the sense of like they'll still feel pain because it's coming from the neck or the jaw. And so that's the one time where I've had people that are classified as neuropathic pain and they don't have neuropathic pain. They have neck pain, jaw pain, and it's referred musculoskeletal pain.
Yep.
And so that's the one caveat I always tell eye care providers, because I've had people that have come to me from neuro-ophthalmology and they're like, no, they said positive Proparacaine challenge, it's neuropathic pain. And I'm like, it went away when we touched your neck. Like, it's not neuropathic, because neuropathic pain is damage along that first, second, third order neuron pathway. And if it's going away when I touch a muscle on your neck, that's the pathophysiology is overlapping, but it's not neuropathic. And that's important because neuropathic pain is so hard to treat.
It is.
You want the neck pain diagnosis. You don't want
it's a little easier
diagnosis.
And just to complicate things just a little, like sometimes you'll put the Proparacaine on there and the patient will say, oh yeah, that's 80% better.
Yeah.
Okay. So it's not cut and dried. It is not clear, black and white at all. It's a process. It's a nuance. It's a clinical investigation, sleuthing, and working closely with the patient to figure those things out.
Yeah.
Yeah.
Now, blessing or curse, because I know a lot of treatment for both neurotrophic keratitis and neuropathic pain, a lot of it's, and dry eye in many ways, is somewhat on the same line until the ending branches, right? Then it really changes. Would you guys mind kind of going over and just explaining kind of how those treatments are all involved?
Inflammation is my number one enemy number one. And I'm always like, what am I going to do to get this inflammation under control? What's the first arrow out of my quiver? So I attack that hard, right? I want to eliminate those drivers that are making the corneal nerves trigger happy and sending that signal to the brain. I want to quiet all those things externally I can see. So we employ a lot of immunomodulators, topical steroids, intense pulse light therapy, believe it or not, Botox, even chemical peels on the skin can help to calm inflammation of the skin that's driving some of this, get this area cleaned up, treat the Demodex, all those sorts of things. So that's my first target, unless it's clearly more of a centralized issue, in which case I'm quick to pull out things like nortriptyline, gabapentin, pregabalin. CGRP antagonists can be very helpful, particularly in the case of that migraineur, trigeminal neuralgia patient with centralized pain. That those CGRP antagonists can be brilliant if you can get it through the insurance company shenaniganery. Don't get me started on that one. But that combination of things is how I go about it.
Yeah. So similar but different. In my clinic, we have a big rule. All of the providers have a rule that is you cure the patient by chasing the symptom generator, not the symptom. And so the big thing for us is if inflammation is present, treat the inflammation. And that's where with neurotrophic keratitis and neuropathic pain, depending on how long they've had it, they probably also have some inflammation. And you can treat the inflammation. But I always give the caveat to the patient of, I see that you have meibomian gland dysfunction, but based on we're going to fix that, but I don't think your symptoms are going to go away once it's fixed. But we need to fix it because it'll help reduce the chronification of what we're doing. I think that's really important. So what are the big steps for us? So treat the inflammation if inflammation is present. For me, the big one is we need to coat the surface because oftentimes there is just not enough tear on the surface. And so just getting them to use anything sometimes, because a lot of my patients don't know they have dry eye. Because they don't know that I had a car accident and somehow my eyes are dry. And people don't recognize that people with a history of brain injury have more dry eye than the general population. I think there's just a lot of misnomers on that. And so the first thing is, let's just try lubrication. And the big thing is it's a stepwise process. And letting the patient know that it's going to we have to do it one step at a time. Now, obviously, if somebody comes in and it's just a grade 3, grade 4, you start there. You're like, okay, we have to go on, a Senegraman or something like we have to hit it really hard because you're at risk of losing your vision at this point. Or for me, I'm a really big fan of co-managing. So again, I'm not a corneal specialist. So if I'm seeing grade 2, grade 3 neurotrophic keratitis, they're very nicely going to the corneal specialist that is a block away from my office, because that's when you're in the territory of surgical co-management. And my big thing has always been, if I'm not well-versed in surgical treatments for patients, then I'm not giving the patient the best options available to them at the time. If they're a grade 2, grade 3. For me, and I think that's where optometry can shine, is in the grade 1, where it's like grade 1, the treatment options are pretty much the same. There's no surgical option on the board. I'm not holding them back from any treatment option. And sometimes I'll do a lot of consults. I will say our oculoplast and our corneal specialists work in a practice that just down the road from mine. And especially, so we have an inpatient center. And I've done a lot of dry eye talks for our inpatient brain injury unit, and I'll get pictures and they'll be like, what do you think of this patient while they're sleeping? And they had complete facial reconstruction. And so it's like, oh, I can see the entire inferior half of their eye while they're asleep. And so I will quickly just consult with oculoplastics of, do you want to see them, or you want me to, what do you want, how would you like me to attack this for you? Because a lot of times you need surgical repair. So the big thing for me is eyelid anatomy, orbital anatomy. If somebody had any type of, plastics work done, making sure, because the other thing too is scar tissue. You might have had an injury or gone for, a facelift on your own, however you want to do it, but we all heal differently.
Don't do your own facelift.
Don't do it. Don't go to Mexico to get it done also. Fun fact. But the thing is that the surgeon can be perfect, but you might heal unexpectedly. You might have some surgical scarring.
Might be robust. Yes.
And then the problem with that is then when you have contraction of the skin tissue with the scar, you have an abnormal anatomy, nothing to do with the surgeon's skill.
Yeah.
Nothing to do with the surgeon's skill. And now you're dealing with that. And so the big thing for me when it comes to treatment is making sure that have a stepwise process of where you're going. You know the risks of where the patient is in their condition, and letting the patient know that if we try all of it on day 1, we're not going to know what's actually fixing it. So that's the other thing too, of we have to make our best guess, and if it doesn't work, come back and we'll go to step 2.
I love that, and I wish I had that kind of discipline. I've never been a linear thinker. I'm like, I see all these mischief makers. I'm going to pounce on all of them. I want to get you better first, and then we'll figure it out later. Like, I want to get you better.
Yeah. I think, and again, it goes on the level of where they are when they come in.
Yes, that's part of it as well. They come in and not doing great. So.
Now, certainly the treatment of the ocular surface is a huge component that both of you guys are doing. But then there's other people who are really advanced when they are having true pain. Then that comes in a whole other bag of, okay, now we need to manage with someone else, like a pain management doctor. How, you kind of mentioned co-management, but how do you, Laura, starting with you, how do you deal with patients who are in that level of extreme pain?
Yeah, so it's tricky, right? So I'm comfortable with a certain amount of these pain management medications. I'm comfortable with nortriptyline, I'm comfortable with gabapentin, pregabalin, CGRP antagonists. Where I get a little uneasy is low-dose naltrexone, and I shouldn't be, but I just am, because it's hard to get off of it once you're on it, and I'd rather pain management specialists do that. Ketamine, nasal spray or infusions can be very helpful for those severe recalcitrant neuropathic or pain patients. We also do PRP or platelet-rich plasma in office, and that can help promote corneal nerve healing and improvement in corneal sensation as well as fill in the keratitis. So I love PRP for that. What's resonating for me is a lot of the patients come in very anxious because they are in so much discomfort, and pain does create anxiety, right? So step number one, to treat the disease, put the mind at ease. It's like, we're here, we're together, I don't give up, and we're going to figure this out, right? So to get that anxiety turned down to where the patient can hear what you're offering and suggesting, I think is an important first step. It's also important in getting them on board with, I'm going to need help from some of our colleagues. I'm going to need to refer you to Dr. Fisk in Bellevue. He does an amazing job with pain management. So it's that surround sound care, I think, is what our patients need and deserve. And you have an awesome multi-specialty center. I referred out to small clinics here in Seattle, but I think that multidisciplinary approach is very important. And just don't forget the patient's emotional well-being part. Check in with them on how they're doing, because that a little bit of reassurance can go an awful long way. And just getting that anxiety turned down can be very helpful in the whole recovery process.
So, and I'm so glad you touched on that, because what I was going to add on that was, in the definition of pain, it is a physical problem with an emotional component. And you have to acknowledge when you work with someone in chronic pain, and that's what chronic dry eye is, and neuropathic pain, they are chronic pain conditions, and that has an emotional component to it. And that's what makes pain hard to manage is, number one, it's very variable. I've had, someone who, and what is a 10 out of 10 pain? Well, it'll depend. It'll depend on their pain history. If I was in Vietnam and was stabbed in the chest, my 10 might be higher than the average person whose 10 is stubbing their toe. Although I would argue, having stubbed my toe, that's a pretty big pain. But that 10 is different. So if someone who tells me they're a Vietnam veteran who has injury from war tells me they're a 4, that 4 might be a 7, right? Yeah. So it's like, okay, first there's the pain scale issue. The other thing is that what pain they're going to tell me is going to be based off of how they feel that morning when they got to my office. If they had a fight with their spouse and they're in a bad mood, man, is their pain worse. This is the worst pain of my life.
Sleep.
Sleep. And that's where, in addition, and if you look at pain management, some of the things that surprise people on what makes pain better, acupuncture, yoga, antidepressants, and everyone's trying to find the pathophysiology of it, and it's treating the emotional component to pain. I call emotion the magnifier. It will not fix 100% of the pain, because the pain's not coming from emotion, but maybe your pain is a 2, but it got ignored, and then you Googled and you think you have something wrong, and no one's working it up, so now you're more worried that someone's missing something. And then the hard part too with neuropathic pain is, you come see more specialists, they do more tests, everything keeps coming back normal, and then we're telling you you're normal, which should make you feel great, like, but something's wrong. Then you think someone's missing something, and you can see where that anxiety is going to come from. And because you're worried that, well, Google already told you have cancer, so that's always the first one. It's like you're worried someone somehow missed cancer. And then infiltrates your life. And I think that's the big thing we see in our clinic and is our patients, it impacts your relationship with your spouse. It impacts your relationship with your kids. You can't enjoy life. And then you have the psychological component. So there is something out there for people called a health psychologist. It's a psychologist who deals with people who have chronic health conditions. So I think that's been a referral that we place for a lot of our patients anyways, post-stroke, post-brain injury. There are a lot of, the other aspects of pain. When I'm in pain, I get tense. So I have tense shoulders in addition to having eye pain. So then, working on all of those, I think is the key. And the hard part, I think the hardest part is finding the pain management specialist.
Yeah, that's hard.
Because it's not one specific field of medicine. It's kind of like a certain, and correct me if I'm wrong, but in my experience, it's sometimes an anesthesiologist, sometimes a physiatrist,
when I
sometimes a neurologist.
An anesthesiologist,
and so it's someone who kind of got into their profession, took an interest in pain, and went down the kind of board certification for pain. And so as someone who's not a physician trying to find a pain management specialist for someone in another area, I struggle sometimes. And I have to use my own network of brain, because that's the key, right? Brain injury is used to pain, so I'll seed out all my brain injury people in the area and be like, who do you send to for pain? Or, and that's the other key, is I'll ask my corneal specialist, do you like to see corneal pain or neuropathic pain? And oftentimes they say no, and I go, great, who do you send it to? So that I can figure out where to send them. Because not all anesthesiologists want to see pain, and not all corneal specialists want to see pain. So
we're touching on a really important topic, and so this is a very complex topic, but I think touching on the fact the mental health, the emotional health, just having discussions and understanding where our patients are is a huge topic, and I think we need to certainly discuss it more. And I think it's something as providers we need to maybe, we get so deep into the pathophys and the treatment options and what can we do right now to prescribe. It's like we need to pull back a little bit and really try to take a big picture of what our patient's dealing with in their life. I think it all kind of is interconnected.
And then sleep.
And sleep.
And then sleep. Sleep is
if
super
someone
important.
is not sleeping, they're not going to get better. And I always tell them that. I was like, you have to manage your sleep first. Like, we can't get you to feel better if you're not sleeping. So there's also sleep management in that care protocol as well. So
for our patients, anybody who's a patient who may be watching or listening to this, what sort of, is there any advice that we could give them if they are feeling these symptoms, they're feeling this frustration of what they can do to seek better care? Any thoughts? Is there a kind of something that they can do?
Well, I think trying to organize your timeline of your sequence of events that's happened so that you have an organized timeline to present to your patient or to your doctor, I think is an important thing. Or keep well-organized medical records of what you've done, when, and even maybe categorize it by labs, imaging, which doctors you've seen, et cetera. Stay really well-organized with your workups, with your clinic notes. And don't be afraid to talk to your doctor about the emotional component. It's okay to need a little bit of support in that way, whether it's a little bit of pharmacologic, a referral to a behavioralist who can help you with cognitive behavioral therapy, whatever that is. Like, it's okay to admit that and to reach out and to let your doc know that that's an issue for you and help you get connected in those resources. And then lastly, don't give up hope. Science, medical science doubles every 76 days. And I'm still optimistic that we will have incredibly effective methods of addressing some of these complex clinical situations.
Yeah, and I think that's, the hope thing is great for me, because I would say 5 years ago when I was talking about dry eye and I was like, the dry eye I'm seeing is different, guys. And everyone was like, no, like, you're just not doing it right. And now everyone's kind of got peaked ears because we've got pipelines coming down that are in that neurosensory part. The part we're due to finally acknowledge that neurosensory is a aspect was helpful, because I think that's what for me has been missing in all the dry eye literature is everyone's just been talking about inflammation. And once you've treated the inflammation and it's persisting, now what?
Yeah.
And I think the last thing would be, And I always say loop in your provider. Your provider is never, I have never met a doctor who intentionally is not treating you appropriately or sending you where you want to go. Sometimes I think people are afraid to send to specialists for whatever reason. And I think the big thing I always get, whether it's, and I say that I've talked to other low vision specialists or in neuro is, my goal is never to see you forever for everything. It is to treat my area of specialty and then get you back to your regular provider for your routine care. And so, it's one of those things when I see something like, oh yeah, I see a dry eye specialist, and I look up the provider, I'm like, they're a specialist of everything. They specialize in everything. And I'm a big fan of, jack of all trades, master of none. If you do everything in your practice, it's impossible to be really good. And there is sometimes help in co-managing. It's not replacing one provider for another. It's getting a second opinion and then working in it as a team. And I think that is the big one is and also recognizing it as, for me as an eye care provider, when someone's like, I'm going to get a second opinion with someone else, and they're a tough case, I'm like, great, let me send the notes.
Keep me in the loop. Like, I'm happy to collaborate. Here's my cell phone number.
They can call me.
Would love to hear from this talk. Like, let's put our heads together.
And I think that's, patients are so afraid that like I'm going to take it personally.
We don't take it personally.
No, and it's at the end of the day, we all just want to get people to get better.
Yes.
And I think all of us can put our ego aside for a great consult, and then we learn. And that's the other thing too, that I think will help all of the profession, is if you did something that we didn't tell you to do that got you better, let us know.
Yeah, share it with us. You might be helping other patients.
Exactly. Yeah. The feedback can be helpful.
Well, I can't thank you awesome doctors so much for being on this and sharing some of your insights. I know there's so much more that we could talk into. I know both of you could
go for a long ways.
Yeah, I know both of you could give lectures on this for 2, 3, 4 hours plus. So I still can't thank you enough for sharing your knowledge here with us today. And from here, we'll see what else we can do for the eyes.
Future looks bright.
Thanks.
You've been listening to the Dr. Eye Health Podcast with Dr. Joseph Allen. For more resources, trusted information, and helpful tools, visit dreyehealth.com. Thanks for joining the community that's focused on healthier eyes and a healthier life. Until next time, stay informed and keep your vision sharp.